And I wanted to welcome everyone to our webinar today on how can employers lower healthcare costs using VBID, which is value-based insurance design. A lot of exciting things happening in the country around value-based insurance design. So let me start out with our usual webinar disclaimer. The content of this webinar is provided solely for informational purposes. The information should not be relied upon as a substitute for legal, accounting, tax, and other professional advice. Please contact your employment attorney for legal advice. Always have to get that in. So value-based insurance design, we're going to cover the following topics today. First is healthcare costs and what is the real issue and why costs are so high. Second, talk about value-based insurance design, which includes direct primary care, independent third-party administrators, Medicare management, transparent medical markets, bundled surgical direct contracting, stop-loss management, transparent pharmacy, reference-based pricing, which may be something new to most of you, and concierge services. So we'll start out talking about healthcare costs and what's the real issue. Healthcare spending is over $3 trillion, which is over $10,000 a person. It's 19% of our gross domestic product. It's 2 times the next industrialized nation. So we're talking about large nations, Canada, England, France, Germany, etc. But our costs are 2 times what those others are. Fortune 500 CFOs think that 96% believe that healthcare is broken. 97% believe that employers have to take the lead and not insurance carriers or the government. 81% believe that healthcare costs are draining resources. And 97% say they need more data on price and quality. We'll talk about that a little bit later. And 80% really believe they're powerless to manage their spend, which we don't believe is really true, but CFOs believe it's true. So where do claim dollars go? This is fascinating to me because 17% go to pharmacy, but a number of years ago, like 10 years ago, that was 6%. Professional services is 31%, inpatient hospital 30%, outpatient 19%, and other 4%. But obviously, pharmacy is growing as part of the healthcare spend. Under the Affordable Care Act, there's an 80-20 or 85-15% rule. And what this means basically is that insurance carriers have to spend in the under 100 market 20% on general and administrative expenses, including sales and marketing, and 80% on healthcare. In the large market over 100, it's an 85-15% medical loss ratio. So if claim costs go up, the insurance carriers can charge more. There's no incentive in the Affordable Care Act to lower healthcare costs. And here's an example of it. An MRI that's $500 for an MRI, a carrier can charge in premium dollars $625. But if the MRI costs $2,000, they can collect $2,500 in premium to reach the 80-20 or the 85-15 rule. So if they're paying higher costs for an MRI, they can actually keep more if they pay more. And I'll give you a quick story. We have a client, we had a client for 10 years who actually closed up last year. And this client was a imaging facility in West Los Angeles. They did MRIs, CAT scans, PET scans, and they charged $500, or they received $500 from carriers to do this kind of work, where UCLA, a few miles to the east of them, were getting $2,500 for an MRI. So in-network MRIs, they could go to this company, which is in West LA, and have a private MRI facility or an outpatient MRI facility, and the carrier would only get approximately $125 left after healthcare costs. But if it went to UCLA at $2,500, UCLA would be able to charge them, basically a lot more money. for the MRI. So there's no incentive for the carrier to direct clients or employees or consumers to the West LA outpatient facility because they only earned $125 for each MRI, where if they went to UCLA, they get $500. And most people don't understand that this is rampant across the whole system, whether it be hospital services, prescription drugs, imaging, doctor visits, what have you. There's no incentive for the carriers to send people to the lower cost provider, and that's one of the unintended consequences of the Affordable Care Act. Biggest price falls in 2017, and this shows you from some national data what different procedures were the lowest and the highest cost. So for example, knee replacement, which I'm going to have in a little while, 5,449 was the low-cost provider, 88,000 was the higher-cost provider. Laparoscopic hysterectomy, 8,000 to 57,000. A hernia, 5,000 to 37,000. We'll give you a hernia example in a little bit. So what you'll find across the country is whether you use outpatient surgery or hospitals, whether you just look at California or Western US or national, but there's a wide price disparity between costs. MRI of the brain was one that caught my eye, which is the one on the right here. $750 for an outpatient facility, up to almost $24,000 for a hospital MRI for a brain scan. So essentially, healthcare is broken. The usual patient experience is that there's no transparency. They go to the facility their doctor sends them to. There's no understanding of out-of-network costs and balanced billing. There's no understanding of drug costs and co-pays and how that whole system works. Most doctors will say, don't worry about it, your insurance will cover it. Well, if you're in network, your insurance will cover it, but you have no idea what the cost really is until you get your explanation of benefits afterwards. Consumers don't shop for healthcare. They do shop for cars, homes, appliances, what have you. They can compare price, quality, and features, but with healthcare, they have no way of comparing. They could go to some online resources to compare prices, but they have no idea what their insurance carrier's price is in network or out of network. And therefore, a patient has no incentive to really figure out what's the best for price, quality, etc. Moving forward, the usual solutions, and this is something we picked up from a company called Sano Surgery out of Arizona. One is don't have surgery, because sometimes you don't really need surgery, but doctors will recommend it because the only way they get paid is to have surgery. Make second opinions mandatory. There's some experiential data from Sano Surgery that basically says that 30% of surgeries weren't necessary after the second opinion. Get out of the hospital. 23 million out of 70 million cases were performed in surgery centers. There's 5,500 approximately surgery centers in the US, and the average number of cases a surgery center has is 4,200 a year. But there's 48 million eligible cases performed in hospitals, according to Hopkins Medical. And if you have good medical management and good data on price and quality, you can lower costs by using surgical centers, and that's one of the examples. And we'll show you an example later with the County of Santa Barbara. So what is value-based insurance design? Value-based insurance design is where the employers manage healthcare costs independent of insurance carriers. And this is happening all across the country, not necessarily in California yet, but it is happening in California for larger companies above, let's say, 300 employees. But value-based insurance design employs the following areas: direct primary care. So basically, you're signing a contract with a direct primary care facility. We'll talk about all of these items in a little bit. Direct contracting with labs and x-rays. Direct contracting with surgical centers and hospitals. and using an independent pharmacy benefit manager to lower healthcare costs or drug costs. Hiring a third-party administrator to handle the administration of claims and payment for services, using a new concept called reference-based pricing, and making sure that medical costs are transparent to the employer and to all the employees of that company. The American Medical Association just released a report strongly endorsing value-based insurance design to align clinical and financial incentives. So value-based insurance design is, I'm not going to say sweeping the country, but it's growing rapidly, and actually it's growing exponentially around the country and in other states. In California, it's growing very slow right now. So value-based insurance design uses independently managed risk sharing. So right now, most companies are fully insured under 300 employees. 100% of the premiums non-refundable. You pay for the employees even if they don't use the health care or the health coverage. And there's really no way of reducing claim costs. I mean, if you reduce claim costs, you have little or no effect on premium costs. And this goes up in California up to 250 employees that are enrolled. If you use the main carriers in California, which would be Aetna, Anthem, Cigna, Blue Shield, Kaiser, United Healthcare, and HealthNet, you can look at the plans they have available up to 250 employees, but in reality, they're fixed plans. The Blue Shield may have 16 plans and 30 different drug combinations, but you're stuck with those combinations. And if your base of employees get healthier, it doesn't really affect the rates because everything's pooled into one large group. Above 250 employees, there's company-specific claims, which really means the carriers are looking at the claims experience, and you're able to manage the price of your insurance based on the money going in versus the money going out. So the insurance carriers are looking for a certain return on the premium dollars, and if you have large claims, they will raise your rates. In the pooled market, in the under 100 market rather, you don't get really claims data. The only thing you get in California is, are there any large claims? And if you don't have large claims, then you're in this giant pool. Independently managed risk sharing used to be called self-insurance, but we're going to talk about self-insurance and independently managed risk sharing as two separate items. Number one, you know what your maximum claim exposure is every year per employee. You have a stop loss to protect yourself. You rent a PPO network. You use an independent third-party administrator, an independent pharmacy benefit manager, and essentially you can reduce claims by impacting your costs. Now, independently managed risk sharing is different than fully insured, and it's different than self-insured using one of the major carriers as your administrator, which is what most people do. Around the country, 65% of the companies are now self-insured. In California, it's low. It's somewhere around 35 or 40% in the larger market. So let's talk about traditional fully insured all the way to independently managed risk sharing, which is value-based insurance design. Traditionally fully insured, the carrier provides the insurance. In a fully insured with a health reimbursement account, you can probably save 9 to 15% of your costs, but again, you're using a fully insured traditional plan. If you use an ASO or a carrier who's administering the self-insurance, you can probably save 15 to 20% on average over the fully insured product, but you're using a carrier. And the carrier administers the claims. They're the third-party administrator. They use their PBM or their pharmacy benefit manager, which might be Express Scripts. It might be CVS Caremark. But the bottom line is that you don't really control what's happening. Where in an independently managed risk-sharing arrangement, you can manage it, you can use independent pharmacy and independent surgical and independent hospital. You can get away from the insurance companies and the PPO discounts which we have really no idea what those discounts are in reality. And you can save 20% up. There's a firm in North Carolina run by a guy named David Contorno, which we'll talk about him and an experience he had regarding a hernia operation in a little while. But David has been able to bring in value-based insurance design around the country and save employers 30 to 40% in the first year by using a value-based insurance design. So let's talk about direct primary care. Direct primary care is not concierge medicine. Concierge doctors were a big kick, let's say, a couple years ago, where people were going, oh, I'm going to go to this concierge doctor, I'll go to him for everything, but he doesn't accept insurance, and et cetera, et cetera. Direct primary care is a movement of primary care physicians that want to have a better outcomes with their patients. So a typical primary care physician has 2,500 to 3,000 patients and spends an average of 16 minutes with each patient, where a direct primary care doctor has only 600 to 800 patients, and they spend an average of 60 minutes with each patient. Initial appointments with direct primary care doctors are 1.5 to 2 hours. They're basically talking to the patient, learning about them, talking about things, getting to know them. Kind of reminds you when you were a kid and you had one family doctor. This is kind of going back to the family doctor, where the family doctor spends time with you, knows you and your family, takes good care of you, and it's not every 15 minutes they're seeing, 4 patients an hour, which is what happens with most physicians. It's covered by a flat monthly fee. They don't take insurance, so that flat monthly fee will take care of all your services, and they handle acute care, chronic disease management, preventive care, lifestyle coaching, same-day appointments 80% of the time, or next-day appointments, and they're available 24/7. So they're available by phone, they're available by video, on laptops and smartphones, and it reduces unneeded and duplicate tests because your primary care physician knows more about you. So as an example, or moving on, let me go to the next slide and I'll talk more about direct primary care. What Direct Primary Care Coalition, which is made up of all the direct primary care doctors in the country, what they found are they're getting better health outcomes through better access to physicians, lower costs because of the flat monthly fee, enhanced patient experience by creating a relationship. So they're creating relationships again with doctors, where you had it in the old days, where now I get to see my doctor, my primary care doctor, 4 times a year for 15 minutes each time. 60% fewer hospital admissions, 60% decrease in emergency room visits, 30% fewer days spent in the hospital, and fewer specialty visits. Because what happens now in the fully insured market or in the carrier market is that your primary care physician will send you to a specialist quickly. They're worried about medical malpractice. They're worried about not being able to have a relationship regarding certain specialties, so they send you to a specialist. DPC is now operating in 48 states in the United States with over 1,000 DPC offices. And what companies are doing is they're setting up value-based insurance design, but they're not saying that you have to go to direct primary care, but you can go to your other doctors and you are covered by the underlying insurance or the underlying stop loss. But if you go to direct primary care, there's no costs. And I'll show you that with some hospital examples. But essentially, if you go to your regular physician, you pay $30 office visit. If you use the DPC physicians, you have no office visit, no cost at all. Independent third-party administrators, I talked about this a little bit, that if you use a carrier who's administering things versus an independent TPA processes claims, they adjudicate bills, they do all the record keeping. 60% of employees are being used by TPAs now versus the federal government. This is nationally because 60% are self-insured. TPAs don't have to use traditional insurance markets or provider networks or pharmacy benefit managers, because an independent TPA can work with an employer and with direct contracting to where they're not using the rented PPO network that the carriers have. And it ends up being a better situation because the independent TPA can manage the claims differently than a carrier ASO. Along with an independent TPA, what companies do in this space is they hire a medical care management company. And the medical care management company ends up being like the central nervous system of your plan. It helps employees navigate the health plan because employees, when besides seeing the primary care physician, the direct primary care physician, they end up calling the medical care management company who talks them through specialists. They require pre-certifications, they require second opinions, they look at catastrophic case management, cancer case management. They're looking at who the better providers are with the highest quality, with the least amount of infections, the least amount of repeat procedures, the least amount of hospital readmissions. And so they're managing the employees to high quality service. And that ends up helping the employees and also lower the costs. They have disease management and wellness management too, and they help along with the pharmacy benefit manager to do advanced drug cost management. These companies are located around the country. There's one called AIM, A-I-M-M, which is Alt in International Medical Management. Deborah Alt and her husband own the company. And you might want to just Google Deborah Alt and you'll learn a little bit about what they do and how they operate. But as I say, there's many companies around the country that do medical care management. And these employers are requiring their employees to call the 800 number or have the video call with a Medicare management company in order to get better outcomes, better quality, and lower costs. So whenever you're having value-based insurance design or the old style self-insurance, you always have stop-loss coverage. Stop-loss coverage limits the employer's exposure. 80% of employees spend very little on health care. And I'll give you a couple of examples. And here's one which is my personal example. I'm 64. I go to my regular doctor 4 times a year. I go to my oncologist 2 times a year because I had leukemia and he checks me twice a year. I go to the doctor 6 times a year. I have a couple chronic issues. I'm pre-diabetic and, you know, my blood pressure, they want to watch it and they want to watch my meds. But so far through today, December 12th, I have spent $784 of my $1,000 deductible, and my out-of-pocket maximum, which is $6,000, I've only spent $2,342. So essentially, my personal health insurance is costing about $14,000 a year for a PPO with a $1,000 deductible. And of that $14,000 a year, if I was self-insured, my employer would have only spent $2,342 rather than $14,000. That's an example. But I'm a 64-year-old person with issues. If you take people in their 20s and 30s but only go to the doctor once or twice a year, go for a wellness exam, maybe go for a flu shot, maybe go to an OBGYN a couple times a year, the costs are a lot less than what the insurance is costing. So the idea with value-based insurance design and also self-insurance is that the employer covers those routine costs. And then when you get higher costs, you're covered by stop loss. So there's 2 types of stop loss. One is specific stop loss, which covers each employee up to a certain deductible level. So it might say the employer is going to cover all expenses for each employee up to $25,000. However, there's an aggregate stop loss for catastrophic claims. It says that if the aggregate claims gets above a certain dollar amount, that might be $100,000, that then the stop loss kicks in. I like to use the car insurance example because health insurance has really changed. We go to get health insurance and we expect it to cover everything. Where with car insurance, we don't buy car insurance to have our tires rotated and our oil changed. We go to get car insurance to handle the important stuff when we have an accident. When we have an accident where our car needs a lot of help. There was one person on the call today who just was in a car accident and their car was totaled and they're having some, experiences that they have to go to the doctor, physical therapy, what have you. We buy car insurance for that kind of thing. We don't buy it to rotate the tires. And the same thing with health insurance. If we go back to the old days where people covered their own minor costs, or in this case, the employer covers the minor costs, the routine costs, and have stop loss to cover the large things, you can really lower your costs dramatically. Typical self-insurance lowers costs by 20%, 15 to 20%, but value-based insurance design can lower costs by 30, 40%, which is actually pretty exciting when you think about it. So a stop loss example, you might have a $100,000 aggregate specific deductible. You might have a $50,000 deductible for each member. So all the employer pays all the expenses up to $50,000 for each member. But remember that 95% of employees never go to the hospital in any year. So 95% of employees, the only thing they're going to do is go to doctors, maybe have a scan, but they never have high costs. 5% of the population has hospital every year or have costs associated with chemotherapy or what have you, and those are major costs. So once those costs get above $50,000, as an example, the stop loss kicks in, and it protects the employer and lowers the employer liability. The other thing with value-based insurance design is that the employer can manage, based on data, which we'll talk about in a little while, they can manage what's happening inside their employee base. They can go to the employees that have chronic issues and help them get healthier with lifestyle coaching. They can help people that are, let's say, obese or heavy lose weight. They can help people that have diabetes do a better job of managing it, or high cholesterol or what have you. So let's talk about choosing doctors, because that has to do with value-based insurance design, has to do with quality. Most people choose a doctor because they ask their friends, who's your primary care doctor? Who's your doctor? And when you have a primary care doctor and you need a specialist, they usually refer you to somebody. And the problem with that is we have no idea who we're getting referred to and how good they are. You can go online and look at a couple of databases which talks about quality ratings, but it's not specific information. And I'll give you a quick example. When I had a colonoscopy at 50 and then I had a colonoscopy at 60, I used a doctor that was near my family doctor in West Hills, California. I have no idea how many colonoscopies this guy does. I have no idea whether he has infection rates. I have no idea whether he has patients admitted to the hospital after a colonoscopy. I just know that my doctor said, go to this guy, all my patients go here. So I'll give you a quick example. Dr. Lickerman, who is out of Chicago, he runs a direct primary care practice called Imagine MD. Dr. Lickerman spent some time with me in San Diego with a group of firms that we're affiliated with, and he was talking about the fact that he needed elbow surgery last year. And he's a doctor and he knows some specialists and he knows an orthopedic guy, and he had an elbow surgery done. And then he started learning more about value-based insurance design and meeting with people like Quantros, which is listed at the bottom here as a source. And there's a database that has 30 million discharges in 50 states from hospitals, 4,500 hospitals and 200,000 physicians. And if he would have gone to this database and he were to look up this doctor, what he learned was the doctor had a quality rating of 30%. Not 90% or 85%, but 30%. And this database also has mortality rates, complication rates, readmission rates, infection rates, etc. And Dr. Lichtman realized that he went to this doctor because a friend of him said, oh, this is an orthopedic doctor in Chicago. The guy's a great guy, and I've known him for 20 years, and you should go to him. When in reality, when you looked at the data, the guy didn't do a lot of elbow surgeries, and his overall rating was lower. So there is information out there, but the regular consumer can't receive. But if you have a value-based insurance design, you can get this information, and then you can ask your employees to use certain facilities that have higher ratings, less complications, etc. And I'm going to give you an example in just a little bit about that. The other thing that's a problem with our system right now is that when we go to the doctor and we have to have surgery, we get a bill from the hospital, we get a bill from the surgeon, we get a bill from the assistant surgeon, we get a bill from the anesthesiologist, sometimes a pathologist. And the problem in most states are that if you use an in-network hospital and an in-network surgeon, that doesn't mean that your anesthesiologist will be in-network. So your anesthesiologist most of the time is out of network. And your assistant surgeon might be out of network. So you end up with a hospital bill, but it's not one bill, it's 5 or 6 bills, and some of them may be out of network. So instead of getting an 80-20 split on in-network hospital and in-network surgeon, you get a 50-50 split, and the assistant surgeon and the anesthesiologist are paid 50% of the carrier's fee schedule, and then they balance bill you for the rest. So what's happening around the country with value-based insurance design is bundled surgical, where you go to a facility and you say, what's the price for a surgery all in, everything included? You know the cost ahead of time, you don't receive bills, you get one price. And I'm going to give you an example. I mentioned David Contorno earlier. He's actually a thought leader around the country in value-based insurance design. As some of you know, we're members of Q4 Intelligence, or Q4I, which are a group of 35 HR and employee benefit firms around the country in 30 states, and we meet every 9 months for best practices, and we have monthly phone calls and what have you. And David Contorno is one of our members. And David needed a hernia operation beginning of the year, and he got on the phone and he got really smart, and he hired a video crew to video him, and he called every hospital in North Carolina where he lives and asked the following questions. I need to have a hernia operation. The diagnostic code is 1, 2, 3, 4. How many did you do last year? How many readmissions did you have? What was your infection rate? And a few other questions. What's your price? And some of the hospitals said, we don't have that information. Some of the hospitals said, well, I can give you the price for the surgery in the hospital, but I can't give you the surgeon price or the assistant surgeon price. You need to call them directly. And then David called the Surgical Center of Oklahoma, in Oklahoma City. And he asked the same questions. And he was told, we did 645 hernia operations last year. We had no infections. We had no readmissions. And our price all in was $5,400. I'm paraphrasing on the 5,400. I don't remember exactly what the number was, where the hospitals in North Carolina gave him prices of $15,000 to $25,000. So what did David do besides videoing the whole thing? He took his whole family to Oklahoma City, and he had a surgery, outpatient surgery in Oklahoma City. He paid the $5,400 with a check. He didn't use his insurance. He had a better outcome, he thinks. And he saved a lot of money. And that's what's happening around the country, is bundled surgical. And it's fascinating because most hospitals can't tell you at all what's going on in the surgery area. And most hospitals can't tell you how many they've done, what the readmission rate was, what the infection rate was, if there are any complications, quality ratings. They just don't have that information. I put the website for Surgery Center of Oklahoma there. I put the pricing link. If you go on there, they list every single surgery they do and what the price is. So you know up front what it is. So let me give you a real life example in California, which is County of Santa Barbara. I keep hearing information all around the country in some of the webinars I go to and meetings I go to about, well, the County of Santa Barbara sends people to San Diego and they put people up for a week at a hotel and, you know, et cetera, et cetera. Well, here's what I learned. I went to the County of Santa Barbara website and I looked at their health plans, which are on the website, and here's what we learned. They have Blue Shield. They have 4 Blue Shield plans, 2 HMO, 2 PPO. And they also have something called Carum Health. And Carum Health is really interesting because if you go to Carum Health, you get elective surgery at Scripps in San Diego, at Stanford Valley Care Hospital, at Providence St. John's in Santa Monica, and at Hoag Orthopedic in Orange County. County of Santa Barbara covers your travel and lodging expenses for your family. There's 80 outpatient procedures that you can use and some inpatient surgeries. And if you use Carum Health, no out-of-pocket costs, no deductible, no co-pays, no co-insurance. In other words, if the employee of the County of Santa Barbara says, I'm not going to have my surgery done in Santa Barbara County or Ventura County with Blue Shield, but instead I'm going to go to Carum Health and use Scripps in San Diego, there are no costs to the employee at all. And what County of Santa Barbara's done is they lowered their total cost by 50% on these outpatient surgeries. Okay, so they are self-insured. They use Blue Shield as an ASO, but for surgeries, they say you have a choice. You can go to use Blue Shield plan at the hospitals in Santa Barbara. You can pay your $1,000 deductible or your $2,000 deductible. You can pay your 20% co-insurance, or if you want to go to Scripps or Stanford or Providence, you have no out-of-pocket costs. And that's what they're doing, and it's fascinating what's happening there. So now let's move into drugs. Peeling the onion, the stinky facts about high prescription drugs. 36 million Americans did not fill a prescription last year because of cost. 25% of healthcare spending went to drugs compared to 7% in the 90s. The average retail drug price for patients with chronic conditions are $11,000 a year, according to AARP. Drug prices increased 8 times the rate of inflation for the 30 generic drugs analyzed by the Wall Street Journal. And drugs are having double-digit drug price increases in the past 5 years. Recently, there was an article in the Washington Post, and I just saw this 2 days ago in a website from Benefits Pro magazine, that there are 16 drug companies covering 300 generic drugs that are being sued right now by Attorney General for price fixing. And the problem is, which we'll see in a minute, is that 87% of employers are identifying pharmacy costs as their top priority. Drug manufacturers in the U.S. set their own prices. Probably all of you have heard that drug pricing in Canada is lower, in Europe is lower, and you know, why are you going to get drug prices in drugs here when you can get it cheaper elsewhere? Patents run for 20 years, but sometimes a drug company could tweak something and get a patent for additional time. An example would be a pill that right now you're taking twice a day, which now they come out with a new one which is once a day. We had this experience 10 years ago with one of our kids. When they were 16, they were taking they had an antibiotic, and the doctor prescribed them a drug, and it was like $150, and my wife said, wait a second, that's a lot of money. What about the old drug? And he goes, well, the old drug you had to take 3 times a day, and I thought this might be easier because the kid's 16. My wife said for $150, they can take it 3 times a day. The FDA also takes 3 to 4 years to approve a generic drug. A generic drug has the same equivalent ingredients, active ingredients, as a brand name drug, but why would it take 3 to 4 years? So $6.4 billion was spent on direct-to-consumer advertising last year, and $24 billion was spent marketing to healthcare professionals. So you've probably been in your primary care physician office, you saw somebody come in a suit, and they came in with a briefcase, and the briefcase is full of samples, and the physicians are being told, you know, use this drug, it's better, but the physicians have no idea what those drug costs. So pharmacy benefit managers, and this goes for the Anthems, the Aetnas, the Blue Shields, the Cignas of the world, PBMs handle 80% of drug prescriptions in the US. And as you see from the chart, two of them, Express Scripts Medco and CVS Caremark, represent the two largest groups out there. 155 million people are covered by Express Scripts. CVS Caremark covers 85 million. So just those two cover 75% of the drugs in the US. And there's lack of transparency with this PBMs. It's driving up costs. And there's also conflicts of interest, which we'll talk about on the next slide, I believe. So according to the National Community Pharmacists Association, these are some of the common PBM practices. They charge clients administrative fees for drugs that were not even dispersed. So if you're with Anthem Blue Cross or United Healthcare, by the way, United Healthcare has their own benefit pharmacy management called Optum RX now. Optum's not listed here yet, but Optum RX will be growing because United Healthcare left Express Scripts a year ago. But as an example, the Anthem, Aetna, Blue Shield, Cignas of the world, they get charged admin fees for every time that the script is filled. And sometimes if a prescription was duplicated or reversed or rejected or whatever, they're still getting charged the admin fee. There's also profit spreads hidden. So the prices charged to the health plans may be different than the manufacturers and wholesalers sell to the PBM. Some PBMs are classifying generic drugs as brand names. How's that happening? Well, the carriers now aren't using the terminology generic and brand name and formulary and non-formulary. They're using tier 1, tier 2, tier 3, tier 4. So a PBM might put somebody in a tier 2 when it's a generic, and they're getting a higher value, a higher price for that. The other thing PBMs do is they promote drugs based on manufacturers' rebates. Some of the drug manufacturers or wholesalers will rebate to the PBM money based on certain number of scripts they write and certain drugs that they dispense. PBMs end up preferring brand name drugs because they have higher rebates than generic drugs. So what happens is, your doctor prescribes a drug, it goes through the carrier, the PBM. The PBM says, well, this is not on the formulary, or it is on the formulary, or what have you. But essentially, the PBM controls what's happening, and even the carriers don't know. And as a good example, Anthem is suing Express Scripts right now. And I want to say it's $1 billion, but I'd have to look it up. I don't remember exactly the number. But Anthem decided that Express Scripts was not honoring the contract properly and was gouging them, and they're suing them right now. And part of the problem is auditors. The insurance carriers have the ability to audit, but the auditing isn't being done properly because the PBMs have to approve who the auditors are, and that poses a conflict of interest. So you see some of the problems with the pharmacy benefit managers. So in value-based insurance design, you have an independent pharmacy benefit manager. They're not tied to one of the big ones, Express Scripts or Caremark, CVS. They're not done through a carrier. You hire an independent pharmacy benefit manager. And the independent pharmacy benefit managers are sourcing generic drugs in the US, but brand name drugs are being sourced in New Zealand, Australia, United Kingdom, Canada. The drugs come in original packaging. They're supplied direct from the manufacturer or government licensed wholesaler. So essentially, when an employee goes to a doctor, they get a prescription, they either send it to the pharmacy benefit manager, the doctor does electronically, or they send them a script or what have you. This transparent independent pharmacy benefit manager then looks at the drug, and if it's brand name drug, they source it in one of these 4 countries, and they're saving 50% on the cost of brand name drugs. And what the employers are saying to their employees are, if you go through our regular system, like Santa Barbara County might be, with Blue Shield, you're going to pay $10 tier 1 and $40 tier 2 and $80 tier 3. But if you go through this transparent pharmacy, the prices are cut in half, or maybe there's no cost for your drugs at all. and there's no admin fees. So it's a very transparent system. So let's talk about reference-based pricing. Right now, insurance carriers, if you're in a PPO, which 75% of the nation is, outside of California, 80% of employees are on PPOs, where in California it's only 45%. But around the country, when you go to a PPO, because you want to get the in-network pricing and the in-network discounts. But the question is, what are those discounts and how are they figured out, and how do you know you're getting a good price? And the answer is you don't. So what's happening in the value-based insurance design is that the independent third-party administrator is negotiating with the employee benefit advisor and with the employer reference-based pricing with hospitals, surgical centers, imaging centers, and saying, we're going to pay you a discounted price, and we're going to pay you based on Medicare. We'll pay you 120 or 150 or 170% higher than Medicare, and we'll pay you up front. So you don't have to worry about claims processing. You don't have to worry about waiting for insurance reimbursement. You don't have to worry about doing all the collection work. Because what happens with Medicare is they get 100% of Medicare. So they're already accepting a Medicare payment. So now these hospitals and imaging centers are saying, wow, we'll accept 120 or 140% or 170% of Medicare reimbursement. Providers know exactly what they're going to receive in payments. There's price transparency, and the employer is saving money by doing it this way. Reference-based pricing is growing dramatically in the country, and essentially, right now, most employers are using what's known as the BUCA network, or BUCA network, which is Blue Cross Blue Shield, United Healthcare, Cigna, and Aetna. These are the four biggest carrier. Now, Blue Cross Blue Shield, obviously, it's either Anthem Blue Cross, which covers 14 states, or Independent Blue Cross Blue Shield in various other states, but Blue Cross Blue Shield, United Healthcare, Cigna, Aetna, the classic way that you have health insurance, fully insured, using a PBM that the insurance company has, using the PPO network that the insurance company has. But a lot of people are moving to the non-BUCA network, which is finding your own doctors, your own surgical centers, your own hospitals, aggressively managing costs, aggressively managing outpatient surgery, inpatient surgery, what have you. You can do that using a non-BUCA network where you hire a PPO network and you rent it, but you can also do a reference-based pricing network where you negotiate directly with these providers, and then some companies are using a combination. And the combination is what County of Santa Barbara is doing. They are using Blue Shield and Kaiser in the Santa Barbara area, but also they're using a reference-based pricing network with those four hospitals I mentioned before. So the source of this information is a company called WellNet, which helps employers and employee benefit advisors put together value-based insurance design. So with value-based insurance design, you also have concierge to help the predictability of great healthcare. I mentioned that medical management companies may have concierge services, but sometimes they don't. But this is where an employee will call a concierge regarding medical surgical referrals, medical coaching, imaging diagnostic, medical review, second opinions, etc. And what people have found around the country is that if you use a concierge combined with a medical care management company, and you use value-based insurance design as well as reference-based pricing, you have a much better chance of saving 30 to 40% off of what you're already paying for your insurance, with better outcomes, better quality. So the idea, if you do this, is you have to create educated employees, and you do that by offering them free and low-cost care. So as I mentioned, County of Santa Barbara, you have outpatient surgery at one of those four hospitals. It doesn't cost the employee anything. Where if you use Blue Shield up in the Santa Barbara area, you may have a $1,000 deductible or a $2,000 deductible, and then 20% of the bill and an out-of-pocket cost where, you know, you can use something else. There are 36 database collection points around the country with $1 billion in billion claims in the in the database, and 815,000 physician profiles. So you put this quality platform using a company, independent company like Claris as an example. You look at that compared to paid claims data, and you end up sending people to a high-value network, and a high-value, high-efficient hospital that with better quality ratings. And that's really what's happening. So I just wanted to give an introduction today into value-based insurance design and kind of let you know what's happening. But the idea is you got to put all the pieces together. And it might sound at first that, boy, there's a lot of steps. I just don't have to hire, you know, Anthem Blue Cross of California, and I sign up and I pay my, you know, $100,000 a month in premium, $1.2 million a year, which one of my clients does. Instead, you choose a knowledgeable employee benefit advisor. You get a feasibility study from an actuarial firm. You create a value-based insurance design. Sometimes you do baby steps. You start with a self-insured plan using a bundled administrative services organization like a Blue Cross or a United Healthcare or an Aetna. Or sometimes you just go for it and you go unbundled in the beginning. But sometimes you do baby steps. Baby steps, instead of doing fully self-insured, you might do something known as level funding first, and then self-insured with an ASO, and then direct self-insured. You have to choose an independent TPA, choose a direct primary physician group, medical care management, and then the direct contracting. So you got to put all these steps together. It sounds like a lot of work, but if you have a very good employee benefit advisor that operates in this area, they can save a lot of money over time. So that's basically our webinar for today. I would like to say if anybody has any questions, they can type it in the chat box, and I'll try to answer a question. Next month's webinar will be on California labor law update for 2019, and we'll send that out. As always, this webinar has been recorded, and we'll send out the recording after we upload it to YouTube, and we'll also send everyone who's on the PowerPoint the slide deck. Since seeing no questions then, thank you for being on the webinar today. We look forward to having you at our next webinar in January. Have a great day.